All right, we're gonna get started here. I'm sure a few will trickle in, but hopefully we'll get out at a good time for everybody to run off to lunch. But just really briefly, my name is Megan. I run the NES clinic at the University of Colorado, also volunteer with the Epilepsy Foundation. So they asked me to do some introductions today. And of course, before I introduce Dr. Pellinen here, they wanted me to acknowledge some of the sponsors. And so thank you very much for Charlotte's Web, Jazz Pharmaceuticals, Pharma or PHRMA. I don't know how, am I supposed to say pharma? I don't know. SK Life Sciences for their gold sponsorship of today's event. This session specifically is sponsored by Cerebral Therapeutics. They are a clinical stage biopharmaceutical company dedicated in developing innovative therapies for refractory neurological diseases. So thank you very much for Cerebral Therapeutics. And now we get to introduce Dr. Pellinen here. He is an assistant professor of neurology. Come on in. Come on in. Very informal. Awesome. So Dr. Pellinen is an assistant professor at the neurology neurology at the University of Colorado School of Medicine, is an epileptologist. He works at both the hospital and the VA Regional Medical Center. He went to medical school at the University of Colorado. Did you really? I didn't know that. And trained in neurology and epilepsy at NYU. And then since joining the adult epilepsy group at the University of Colorado, he has become the chair of the Professional Advisory Board for Epilepsy Foundation of Colorado and Wyoming, the director of quality improvement and co-director of continuous EEG for the Division of Epilepsy at CU. And he has spearheaded his department's involvement in the epilepsy learning healthcare system. His research interests include finding ways to improve epilepsy diagnosis, reduce treatment gaps, and improve quality of life with people with epilepsy. So welcome, Dr. Pellinen.
Thank you very much. Kind of introduction, and apologies for anyone from any drug companies here. If I don't mention your drug, I don't need to be absolutely. So I'm going to be talking a little bit about new treatment options. So I have to give credit to David Burdett for the outline of the drug talk today, because he gave a wonderful lecture during AES, the annual Epilepsy Society meeting this year, on some new drugs on the block. I'm going to be kind of mimicking that part for that presentation, for that component, but I'm also going to be talking about a few other things. New treatment options is going to be an extremely loose term. I'm going to focus on new treatment options when it comes to medications and when it comes to some devices, but I'm also going to go over some things like dietary therapy and some aspects of surgery that have been around for a while. But I think people could use a refresher on every once in a while. I feel like I talk to patients in clinic sometimes, and the new dietary therapies, the newer dietary therapies, are somewhat unknown or not discussed very much. So I thought that was important to add in to this talk as well. One disclosure, I have done some advisory board work for SK Life Science. They are not paying me to talk about their medication today. All right, so I'm going to talk about three main drugs that have come out recently, and this is not including, I was reminded that there are new rescue medications as well. That's not going to be a topic that I'm going to talk about today, although it is an important one. I'm going to focus on three relatively new drugs on the block: cenobamate, fenfluramine, and ganaxolone. And I'm going to talk about them in that order. And that so I'll start with cenobamate. It was FDA approved in 2019 for adults with focal epilepsy. Focal epilepsy is the most common type of epilepsy in adults. And all of the meds that I'm going to be talking about have a relatively novel mechanism of action, which is exciting. So they work a little bit differently than the other drugs on the market, which is good news for us, because we're always looking for new tools and new ways of stopping seizures. So the mechanism of action for cenobamate is similar to other drugs. It targets GABA A, but it also works on a certain type of, or a certain component of the sodium current in neurons that's slightly different from other drugs that also work on sodium channels. So it's working on a similar area in a slightly different way, and that leads to different effects, which I'm going to talk a little bit more about now. So the half-life of this medication is 50 to 60 hours. And what that means is how long it lasts in your body. And so this is it lasts a long time. And because of that, most people that take it can get away with once daily dosing. It's recommended for once a day dosing. For people who have very difficult to control seizures, they can't take twice a day. That's sometimes something that we do. As with many of the other anti-seizure medications, it's metabolized by the liver. The liver does a lot to process drugs and other environmental things and hormones. So your liver does a lot for you, and it does a lot to process this drug as well. And that's important to be aware of because that determines some of the interactions it has with other medications. And specifically for people who are going to be starting this medication and for the healthcare providers prescribing it, interactions are important to be aware of. So, and because they are often responsible for many of the side effects. And some of the ones to be aware of are interactions with phenytoin or dilantin. So that drug will decrease the cenobamate concentration in the blood. If somebody is already taking carbamazepine or lamotrigine, cenobamate will reduce blood levels of that, so you have to increase the doses of that medication. And if people are on other medications, and these are older meds, but still ones that we see a lot, phenobarbital, phenytoin, and clobazam or Onfi, cenobamate will boost the drug levels of these meds. So you have to be proactive about reducing the doses of those. And clobazam or Onfi is a common drug that's used. A lot of patients are on that when they're having difficulty controlling seizures. And if you add cenobamate to a drug regimen, you often need to reduce that by half or more. And it's best to be proactive about that in my experience. Especially, so just to give kind of an overview of how this medication is started, it comes in a titration pack, and the dose that people are started on is 12.5 milligrams. And I'll talk a little bit about this on another slide, but every 2 weeks you increase the dose. And I find that by the time people get to about 50 milligrams, you really should have started decreasing some of these other meds by that point. Otherwise, it can cause a lot of fatigue and sleepiness. So, it's not super dangerous, but it's not super fun to be tired all the time. So just to mention some of the side effects, and this is of course important to know if you're thinking about starting a medication. It's important to know for prescribers as well, the common side effects. And I'd say the most common ones that I see are really the top 3 on that list. So fatigue and dizziness and somnolence. And a lot of these are compounded by interactions with other meds. So before I lower the dose of the cenobamate that I'm starting, I'll try adjusting other medications and see if we can get rid of some of these side effects. And that often works, particularly with the clobazam. And then there is a couple warnings to be aware of with this medication. There was DRESS syndrome, which is a severe drug reaction in one patient in a clinical trial. And that was really why we started the titration for this med. So once we started doing the every 2 weeks ramping up, we've been able to avoid this happening again. I don't think it has occurred since then. And if it has, I haven't heard it. So as long as we're titrating up slowly, it seems to be very safe. It's contraindicated in people with a history of familial short QT syndrome, which is a cardiac conduction syndrome, because it can shorten the duration of what's called the QT interval, and that's an interval in your heart rhythm. So if you have a strong family history of heart problems or conduction abnormalities, I would hesitate to start this medication, especially not without guidance of a cardiologist. And then I'm gonna show a couple of figures from the clinical trial because I think that they are very elegant in showing the efficacy of this medication. I'm not going to get too into the weeds on the interpretation of the figures, but I will highlight some of the important points that they show. And a lot of this has to do with the dose responses. So in the upper right-hand corner, you can see the doses from placebo to the high dose, which is 400 milligrams. The range for this medication is a starting dose of 12.5. On the titration, it can go up to a maximum dose of 400 milligrams once a day. And with each increasing dose level in the trial, they found a corresponding reduction in seizures, increased number of people that were considered responders at different levels. And since that figure is a little bit complicated, I'm going to point to two other figures in this paper, which are a little bit more straightforward to understand, I think, and also very telling in terms of its efficacy. On the left-hand figure, you can see on the left side, this is the median change in seizure frequency. So the more negative the number, the fewer seizures people are having on each dose. With increasing doses, there's increasing seizure reduction. And then I think even more interesting is the figure on the right, which actually looked at the number of people who became seizure-free, which we don't always see in these clinical trials for new anti-seizure medications. We're generally recruiting people who have drug-resistant seizures and are looking to be involved in clinical trials. So in that group, it can be a challenge to reduce seizure frequency. And so the fact that this drug was able to achieve seizure freedom for people, and seizure freedom on the high dose up to 30% is impressive in my opinion. So to summarize cenobamate by its strengths and weaknesses, we're excited about it that it has a unique mechanism of action and allows for once-a-day dosing, and it's effective. Some of the weaknesses are not uncommon with certain anti-seizure medications. It can take some time to get up to a therapeutic dose. You increase it slowly every couple of weeks. And then there's, of course, interactions with other drugs and potential side effects to be aware of. No drug is perfect in that sense, so it's stuff that needs to be on your radar as both a patient and a prescriber. All right, any questions on cenobamate before I move on to the next one? All right. So fenfluramine or Fintepla may be a familiar name to some people because it was actually approved in 1973 for initially as for an antidepressant, and then subsequently as an appetite suppressant, which brought it to popularity. And more recently, it's been approved for seizures associated with Dravet in 2020 and Lennox-Gastaut in 2022. And the doses are a little bit different. I'm going to get into this potential side effects with this medication in more detail. But in the past, and kind of what it was taken off the market for was dangerous side effects related to pulmonary hypertension and cardiac disease. And the doses we were using for that, or I wasn't using for appetite suppressant in the past, but this was before me. Those were higher doses than what we're using today. So we generally consider it to be a safer medication the way we're currently using it. So it also has a novel mechanism of action. It modulates what's called the sigma-1 receptor. And what this does is modifies serotonin concentration in the brain. And this is what leads to its effects and side effects. So because of that, it reduces appetite, it reduces seizure frequency, but it also can cause the valvulopathy that is the concerning side effect of this medication. In terms of how long it lasts in the body, it has a half-life of about 20 hours, although there's some metabolites that are longer than that. This means that we it requires twice a day dosing. It's also metabolized in the liver, and it, for that reason, also has effects on other drugs. And in terms of evidence from the literature, we only know it's in combination with stiripentol and onfi or clobazam that increases fenfluramine levels on, but in clinical practice, we would consider just clobazam on its own to be a risk of increasing fenfluramine levels. And then keeping in mind that its effect on the brain is to increase serotonin, any drugs that work against that are going to decrease its efficacy, and drugs that do the same thing are going to increase the risk of a potentially dangerous syndrome called serotonin syndrome. And for that reason, monoamine oxidase inhibitors are contraindicated. They're not very commonly used in practice anymore, but more common things like SSRIs, SNRIs, these are common antidepressants, are frequently used in clinical practice and can increase the risk of serotonin syndrome. So that's something to be aware of. All right, and then side effects to be aware of with this medication are, the main one is decreased appetite, and that's, side effect or effect, that's kind of what it does. So up to 50% of people almost will have that effect. And then you can also get a range of other GI side effects and fatigue. The warning that I'd like to talk about is the valvular heart disease and pulmonary, which then subsequently leads to pulmonary arterial hypertension. And this is what was found, back in the 70s and 80s when this was being used as an appetite suppressant. And because of this, we do have a lot of, the nice thing about having a drug that's been around since the 70s is we have a ton of safety data on it. But that, obviously we're aware of it. And for that reason, it's part of a REMS program, which is a monitoring program required by the FDA. And so you have to sign consent before starting the medication that says you understand the risks. You have to get certain testing before, during, and after treatment. And in this case, it's an ultrasound of your heart. And I'm going to go over a couple of the images, a couple of figures from the clinical trial, because I think they also visually display the efficacy very well. This was from the trial. This was published in last year. The lead author on it is Kelly Knupp, who some of you may know. She's one of our epileptologists at Children's. And so kudos to her on this amazing study. And the figures show the effects on seizures at different doses of fenfluramine. So on the dark bars are the higher dose, the light bars are the low dose. You can see that the low dose actually has a pretty good effect on certain key things. And on the left, so figure or chart B is the maintenance period. So once people have reached the goal dose of the medication, how are their seizures doing? And it seems to make a big impact on generalized tonic-clonic seizures. So it's very effective for that. And then on the right side, you can see at least the high dose had an effect on this group where they grouped tonic and atonic together. And I'm going to focus on that in the next slide because it's actually an interesting finding, because there aren't a ton of effective treatments for drop seizures, which are very disabling type of seizures for people, can cause a lot of injuries when they lose muscle tone and suddenly. And so finding effective treatments for that has been an ongoing goal. And I think that to summarize these charts a little bit, the one on figure A, reduction median percentage of frequency of drop seizures. Once people are on the maintenance dose of both the high and low dose, they have a up to 20% or thereabouts reduction in seizures, in drop seizures. And then In terms of the proportion of patients that experience a reduction in drop seizures, that's outlined in figure B. And I like looking at the maintenance only period. When you combine it with the titration period, it's not as strong of an effect, but that's not unexpected because people aren't at goal doses yet. But it does have a reduction in drop seizures. And one of the interesting parts of this paper, and something I'd like to see in more clinical trials, is highlighted in figure C in the lower left corner. And that's, they asked not just the people who are prescribing the medication, the investigators, what they thought the change was, but they asked the caregivers how they felt the improvement has been. And what was interesting is the caregivers were a bit more optimistic than the investigators. I thought that was interesting because that, you know, they are probably the more important person to ask. Absolutely.
Atonic, is that synonymous with not?
It is.
Okay, that's it.
Yeah, that's just that you experience the drop when all of your muscles become atonic. All right. So to summarize fenfluramine by its strengths and weaknesses, it is a unique mechanism of action, as I mentioned. It has good efficacy, and there's loads of safety data. And the main weakness is that it has this safety concern with the valvulopathy and the need to have regular ultrasounds and a monitoring program to watch for that. And the final drug that I'm going to talk about today is one that's I find fascinating, ganaxolone. It's a synthetic analog of a naturally occurring steroid hormone, allopregnanolone, that had been studied in the epilepsy world for other things for a while. It's been an interest in the field, and it was approved by the FDA in 2022 for seizures associated with a very specific disorder called CDKL5 deficiency disorder, or cyclin-dependent kinase-like deficiency disorder. And to kind of help us understand or kind of orient us to the rest of this drug talk, I'm going to give a really brief summary of what that is. It's an epileptic encephalopathy caused by a specific gene mutation in the X chromosome. So that means that more women or more females than males have it. And this leads to early life seizures and developmental abnormalities. Specifically, children will develop epilepsy by about 3 months of age. It often starts with infantile spasms, hypsarrhythmia, as we heard in the introduction lecture this morning. Can be very scary when they start. And then often you'll have other symptoms that develop as well, and multifocal seizures. And there has never been a specific treatment for this. In terms of the seizure control, we generally use most of the other common seizure medications that are used, like valproate and others. But this drug was approved specifically for this condition. So its mechanism is largely unknown, although it's purported to modulate GABA like many of the other anti-seizure meds. And I'll talk a little bit more about its pharmacodynamics here. So its half-life is 34 hours, and it's metabolized by the liver. And for these reasons, it actually requires 3 times a day dosing. It has effects on other drugs due to the way that it's metabolized. And so there's a whole bunch of drugs that can increase liver metabolism. And so for any of those, you would need to be on higher doses of ganaxolone. Its primary side effects are somnolence, and interestingly, it can also increase body temperature. And this is kind of the primary figure from the clinical trial. Came out last year in Lancet Neurology, and just shows that it's about twice as effective as compared to placebos. So not as a profound an impact on seizure control as the prior 2 medications I discussed. But again, I would make note of the population in which they're studying this drug. and how refractory their seizures are. Okay. So to summarize ganaxolone by its strengths and weaknesses, it is a unique mechanism of action. It's the only approved anti-seizure medication for this specific disorder, but that's also weakness. It's a very narrow indication, but it does open the door for questioning whether or not this is potentially effective for other seizure types and other epilepsies. Part of getting it approved for one thing helps us figure out if it's useful in other areas. So that I would say is a win for the field. Okay. Before I jump into diet and dietary therapy, any questions on the new meds that I discussed? Okay. So I'm going to shift gears a little bit then and talk about diet for a little bit. And I know that Children's Hospital is very experienced with dietary therapy. It's probably more frequently used in children than adults, but we have a diet clinic at the university, and we do dietary therapy in adults as well. And there are some newer ways of doing dietary therapy. So I'm going to kind of summarize what types of dietary therapies there are and what we currently do. These are often used in conjunction with medication, so you rarely use them all by themselves, although I have had some patients want to give that a try. But they are most effective when combined with medications. There are two primary options, particularly that we use here in Colorado. And the first is the ketogenic diet, which is high fat, low carbs. It's monitored closely by a physician and a nutritionist. And it's been shown in all age groups to be effective. And then there's also what's called a modified Atkins diet. I'm going to discuss these in a little bit more detail, what they are, but it's essentially a little bit easier diet to adhere to than the ketogenic diet, has also been shown to be effective. So to get into the weeds a little bit on the ketogenic diet, ketogenic comes from the etymology of that is keto means ketone and genic is producing. And so this is a diet that forces your body to produce ketones, and ketones have been associated with lower frequency of seizures. And ketones are the primary energy source that your body uses when it uses fat as its primary source of energy, which is not typical for humans. We generally use carbs, and that comes from our what we commonly eat: bread, pastas, sugars. And so when you force the body to use primarily fats, you generate ketones. And so the ketogenic diet focuses on trying to exclude carbs from the diet and focus on fats in the diet. And classically, this diet is 3 or 4 grams of fat for every 1 gram of carbs. So you're measuring things out, sticking to a regimen, and it gives your body about 90% of your total calories from fat. Now, that has potential side effects. So when I'm counseling people about whether or not they want to do dietary therapy, a lot of people want to try something that's not a drug because they don't want side effects. And unfortunately, anything that has effects can have side effects. So a diet is not without side effects. And if you adhere really strictly to a ketogenic diet, it can increase your risk of kidney stones, it can increase your cholesterol levels, and it can lead to reduced growth, bone fractures, stuff related to not getting as much calcium. And of course, GI issues are common. Constipation is a frequent occurrence. And so now I'm going to discuss a few other diets, because these are kind of ways that we have worked around the ketogenic diet being very difficult to adhere to and to achieve. So there's a couple other diet options that have been found to be effective for reducing seizure frequencies in certain people. The low glycemic index treatment, or LGIT, is one alternative. And this one monitors for the total amount of carbs consumed and focuses on making sure those carbohydrates are low glycemic index. What that has done is in some people, it's been found to reduce seizure frequency. It also has its own spectrum of side effects, though. It can cause weight reduction, which may not be a bad thing, but it can lead to acidosis, which is actually when the pH of your body decreases a little bit, and that can cause a lot of symptoms and needs to be corrected if that occurs. Another alternative diet is called the medium chain triglyceride, or MCT diet. And that specifically refers to the type of oil that's used in the diet to make it more palatable. This is primarily used in the UK and Canada. I'm not sure if our diet clinic is doing it here. But it's similar to the modified Atkins diet, which we do here. And it's more flexible than the traditional keto diet. It can have some similar side effects. If you're eating a lot of this oil, it can lead to constipation. Often these diets will cause a little bit decreased energy level in general. All right, and now I'm going to talk about modified Atkins diet, what it is. This is, I would say, the most popular one, and at least in our adult diet clinic, it's more achievable for people. Any diet is going to be a big change from what you're used to. So if you go from just eating whatever you want every day and doing you have your own habits, and then you're going to change everything to conform to one of these diets, it's actually going to be effective at controlling seizures. That's a huge change. And so modified Atkins diet may be the more achievable avenue for people. And so with this diet, there's no fluid or calorie restriction. You don't have to weigh and measure all the fats that you eat. And there's no restrictions on proteins. The one thing that you are doing is counting carbs. And it's different from it. What they mean by modified means that they take the traditional Atkins diet and then specify less carbs. So you're limited to 15 to 20 milligrams or 20 grams a day of carbs. And then on top of that, you're just encouraged to consume more fat. And by doing that, some people have definitely been able to control their seizures better. And like I mentioned, we have a diet clinic on the adult side. I presume that almost all the epileptologists at Children's are very familiar with the diet therapy. It's used much more frequently in children. It can be very challenging to get adults who are set in their ways to fully change their diet. So it takes a lot of commitment on the adult side, but we do have a lot of people who've had success with it. So if you have any questions about it, or if you know anyone who needs an appointment, we would happily take your referrals. All right. And then the final topic, second to last topic, I wanted to talk about surgery, because surgery is in general quite underutilized. So about a third of people with epilepsy will be resistant to medications, continue to have seizures despite doing everything we can to optimize meds, but only 5 to 10% will undergo surgery. And that's unfortunate because it can be very effective. There are different types of surgeries. Surgical resections have been around for decades and can potentially cure certain types of epilepsy. And newer surgeries that I'll talk a little bit more about are ablation and neurostimulation. If people have a very focal area of where their seizures are being generated, say there's a clump of neurons that are kind of the perpetrator, we can do a minimally invasive neurosurgery called LIT, or laser interstitial thermal therapy. That essentially will burn away the area of the brain cells that are causing the problems without being hot enough that it affects things like the blood vessels. So it's a very targeted approach. Radiofrequency ablation, or RFA, targets a little bit broader area and can affect more of the seizure network. And then neurostimulation is also kind of the new kid on the block. I'm not going to talk about vagus nerve stimulation, which has been around for a while and is not a brain surgery. But I will get into the weeds a little bit more on responsive neurostimulation and deep brain stimulation, since we still have active clinical trials in these areas. And the first one I'm going to talk about is responsive neurostimulation, or RNS. This is made by a company called NeuroPace. And the device itself is on the left, and so it looks, the part labeled 1 is the battery. So the battery takes up most of the device, and attached to the battery is a little computer chip and a couple of wires that come off of it. And those are electrodes, and those are what we use for monitoring for seizure activity as well as delivering therapy, and which works much similar to a pacemaker. So it monitors and responds to abnormal brain waves. And on the right, you can see how it actually looks placed in the head. It sits in this little, they call it a can. It's what holds the battery and the computer chip in place, and that takes place of part of the skull. So it's actually flush with the surface of the scalp. And it does 3 things. Like I said, it's kind of like a pacemaker. It monitors, detects, and responds. So it's the electrodes are implanted in part of the brain that we've determined is where the seizures are coming from. And it's continuously monitoring the brain waves in that area, and we program it on an individual patient level to recognize their seizure pattern that those electrodes detect. And then we program it to respond to that by delivering an electrical stimulation. So that, much like a pacemaker, detects an abnormal rhythm, shocks it, resets it. It doesn't always work 100% of the time to stop the seizures, but the fact that it recognizes and stimulates every time there's a seizure slowly trains the brain away from having seizures. So it's interrupting them every time they occur. And over time, people will experience fewer and fewer seizures. And that's been borne out in the kind of long-term clinical data, which I'll talk a little bit about. So RNS has been shown to decrease seizures pretty significantly when used correctly, up to 82% reductions at 3 or more years. 3 out of 4 people have had their seizure frequency cut in half by 2 years, and 1 in 3 people had reported seizure-free intervals up to 6 months. So even if they didn't have complete seizure freedom, they'd have long periods of time with no seizures, which is pretty huge. And then, as is becoming more popular to do in clinical trials, which I'm happy about, is they look at other aspects of life too. So what sort of impact does this device have on other domains, and have found that it overall, probably mostly by reducing seizure frequencies, it improves physical, cognitive, and emotional health. And it's so what it was FDA approved for was focal seizures in adults that are resistant to medication. So people who have at least failed trials of 2 anti-seizure medications. And of course, it's considered a palliative surgery, so we use it off-label quite frequently for people in other age groups and other types of epilepsy. And I'm going to talk a little bit more about that in terms of current clinical trials. But before that, I'm going to also talk about its partner in crime, the DBS, deep brain stimulation. So these are the 2 intracranial stimulation options, and they're different in the RNS. You might remember from the picture, we can place those electrodes wherever we want in the brain. So somebody who has seizures that are coming from their frontal lobe or their parietal lobe, different parts of the brain, we can put those electrodes right there, wherever those seizures are coming from. Deep brain stimulation is a more generalized therapy. So it targets the thalamus. We always implant it in the thalamus. And the thalamus is the part of the brain that's often very involved in regional or generalized seizures. It's part of most seizure networks. And so by stimulating it at regular intervals, it's constantly interrupting the seizure network and reducing seizure frequency. And we found that that's, in addition to RNS, we found that's very effective over time. So sometimes when people get the actual implant, they'll have an implant effect. Just by touching the brain, they'll not have seizures for a few months. But after that implant effect goes away, their seizures will come back at more, hopefully not quite back to their baseline frequency, but they'll recur. And then the overall effect of the neurostimulation takes place over months to years. So like I said, you're kind of training the brain to not have seizures by continually interrupting the seizure network from happening. And we stimulate at frequencies that don't interrupt normal cognition. And obviously, we don't want to cause side effects. So we have to pick frequencies that will interrupt the seizure generation without interrupting the normal brain processes. So DBS was approved in 2018. That was actually a fairly delayed approval in the US. It had been around for at least a decade or more in Europe, Australia, and Canada for epilepsy. And it's been used much longer than that in other neurologic diseases. I think the one that people are most familiar with is using DBS for Parkinson's disease, but it's also used in several others, and those target different brain regions involved in those diseases. For epilepsy, we target the thalamus because that's very involved in seizure networks. And DBS was also approved for adults with focal seizures. And like I said, with RNS, we of course use it off-label in other seizure types and other age groups. The general follow-up data and the clinical trial data show that it reduced seizures by about 50% in the first follow-up period. And even in the people who didn't achieve that huge reduction in seizure frequency, often had a reduction in seizure severity, which is key. You know, in a lot of clinical trials, we just do seizure counts without looking at seizure semiology or the symptoms people have. But reducing the actual severity of individual seizures can, for some people, be an even bigger impact than the seizure frequency itself. And as I mentioned, it can take time for DBS to show its full benefit. So the longer you give stimulation to the brain, the more effective it gets. It doesn't, like a lot of drugs, which you hit this effect, and that's what you're going to get. Brain stimulation tends to get more and more and more effective over time, at least up for our follow-up periods right now, which have been 7 to 10 years, depending on who you talk to. So the 7-year follow-up from the DBS study showed that there was a median frequency reduction from baseline of 75% at 7 years. And for bilateral tonic-clonic or convulsive seizures, the frequency was reduced by 71%. And the authors of this paper pointed out, which I think is an important point that we could probably make more in other studies as well, was that by reducing the frequency of generalized tonic-clonic seizures, you're really reducing the risk of sudden unexpected death in epilepsy, sudden unexplained death in epilepsy, because that is much more associated with convulsive seizures, and the more you can make an impact reducing those, the lower risk of SUDEP. All right, and the final thing I'm going to mention is stuff on the horizon. I'm not going to get in the weeds in this because this kind of goes into the realm of unproven stuff, but just something to be excited about. There is an ongoing trial for the RNS for generalized epilepsy. I will say that we've kind of used this off-label a little bit for this indication and have found that it's effective, which kind of spurred us to say, well, let's actually get it approved for this. So we have a trial called the Nautilus trial that we just, at least on the adult side, we joined to show its efficacy in generalized epilepsy. And I suspect it will be shown to be effective, just as DBS has been effective for generalized epilepsy by stimulating the thalamus. In this trial, we're putting the RNS leads in the thalamus, a slightly different part of the thalamus, but we think that that's going to be effective. Then, of course, there are ongoing drug trials. Gene therapy is a hot topic, and they're doing, obviously, most of the work for this is being done at Children's Hospital and in child neurology, because you can make a bigger impact on the course of people's disease when you use gene therapy shortly after birth, rather than by the time they see me. But there are a lot of new devices for seizure monitoring and tracking that are also relatively exciting. People are really into wearables now, watches, and other seizure trackers. There's one that's like a little sticker that goes on the skull. That's a trial that's going on at the university now to monitor for seizure frequency. It can be really hard to keep track of seizures, especially if you're having frequent seizures. And this is seizure frequency is what I would consider a vital sign for people with epilepsy. You really need to follow it closely. That's how you gauge whether or not they're doing responding well to treatment or a change that you made. And it can be very difficult to keep track of seizures. I mean, it's easy if somebody has like one seizure a month, you can kind of stay on top of it. But for people with a more complicated epilepsy types or a variety of different types of seizures, it can be super hard for them to keep track of how many seizures they have on a weekly or monthly basis. And so our technology for devices that they can wear that does it automatically for them is potentially going to be a huge game changer, not just for clinical care, but for clinical trials, where there's also been a lot of concern with the accuracy of data surrounding seizure frequency. And then individualized treatment approaches is a huge topic in medicine for many years now, but we are on top of that in the epilepsy world as well, particularly when it comes to developing seizure prediction models and how to better predict when people are at higher risk for seizures. How can we modify treatment? So maybe someone doesn't need to be on meds every day or every week, or maybe they need to be on more meds at one time of the month or time of the year. And so some of the models that we're creating are to help individualize treatment. Right. Now I have 3 minutes for questions, I think. Do I have 3 minutes? I have a couple minutes for questions. Drugs, devices, diet.
Do you see any success in using diet as an adult if a child's tried it when they're younger? Have failed a bunch of medicines and then tried it.
Kind of like retry it. I've had people retry the diet, because I will, inherit people from Children's Hospital at the adult side, and then we're kind of like, well, what can we try again, or what can we try in a different way? I think it's harder as an adult because people do have habit, you build habits over the years. And so sometimes the modified diets are a little bit more, and then you give it a try for a few months to see, is this sustainable and did it make an impact on my seizures? I've seen it help with other things too, like not just seizure frequency, but if people have migraines, it can effectively reduce those. And sometimes if it doesn't work fully, or it doesn't make that big a difference for seizures, you might want to keep on it because it's helping with some other issue. Yeah.
Even with the new drugs that are coming out, are you still finding that some of the stuff resistant? Or any of them showing, or are you still kind of saying 3 to 4, 2 to 3 to 4?
That's a great question. And I was actually talking about this with somebody else the other day about how we just need to change the definition of drug resistance. Because, this classic definition of, you need to fail 2 anti-seizure meds, and then you're drug resistant, and then you're in this group of people who will never respond to meds. That's not true, okay? I've had several people who are being worked up for epilepsy surgery who I tried a new med with them, and then they didn't need surgery. So you should try medications that are new that you haven't tried before if the current ones that you're on are not working. And this is, so yeah, I won't get on a soapbox about definitions because they change every 5 years. But I think we do need, as a specialty and as a field, we need to consider the fact that with newer medications and newer technologies, we need to reconsider what it means to be resistant. Like, you may not be resistant to something with a new mechanism of action. It's working in a different way. We don't fully understand why everyone has seizures or is at risk of seizures. So yeah.
So you mentioned non-seizure kind of outcomes with RNS specifically, but
Yeah.
there seems to be data coming out with some of the newer medications as well as some of the older. So how are you incorporating maybe some of those questions or assessments around not the seizure frequency, but the overall patient? And how is that sort of impacting your selection of medication kind of moving forward?
Absolutely. I think medications, if you think of medications as just having a bunch of effects, both good and bad, and try to help that to tailor your selection for what might be a good fit for certain people, that's really important because some things that are technically side effects may not be a side effect for that person. If somebody has seizures, migraines, and wants to lose weight, I can pick a drug that causes weight loss, like helps with headaches and reduces seizure frequency. And if somebody's having a lot of mood issues and wants to be on a medication that helps seizures and mood, there's options for that, or anxiety. And then conversely, there are some meds that you want to avoid because they will specifically make those things worse. So definitely with new medications, that's something to consider. We don't have a lot of experience with those sorts of things with fenfluramine and ganaxolone. We don't really use those so much in the adult world. Cenobamate we're using a lot more frequently on the adult side. It hasn't, I haven't found any really beneficial side effects of it. There haven't been a ton of side effects in general. It's been very well tolerated. So but it certainly, they don't assess for all those things in the initial drug trials that the FDA approves them for. So those are things that we monitor more long-term in people.
Great.
Alrighty. Thanks for coming to the symposium today, everyone.
Thank you.